know the hip anatomy to understand why Perthes disease happens. We don't really know why it happens, but it follows a classic clinical pattern. Boys, they're usually 4 to 10 years old, 4 to 8 years old. They'll have an insidious onset of a limp, okay? Mom will just maybe notice they're not really complaining of pain. They just notice that their 5-year-old boy is limping. He used to not limp, now he's limping. What kind of gait will they have? Millenberg gait, usually. Almost always these are unilateral as well. Hip dysplasia, that can be bilateral, right? And they can waddle. And almost always in leg calf Perthes, it's unilateral. And it's a pretty impressive predilection for males, like ratio 4 to 1. It's almost always boys. Who can tell me which hip has the AVN? So you've got to get comfortable looking at growth plates, though. This is not fractured. Okay, look, you know that they're still growing. Their physis is still open. They don't have femoral neck fracture. It's not really a femoral neck, anyways. I was always worried when I started out in ortho, calling a growth, a growth plate a fracture. It just takes practice. Okay. Why? If anybody was to ask you what the pathogenesis is, or what the I don't know if you call this even pathophys, but why is the hip susceptible to AVN? We already talked about it. It's the blood supply. The blood supply is pretty crappy between the ages of 4 to 7. So if you have you can get a transient synovitis, you get a little bit of a septic arthritis, you just outgrow your bone's capability to, your blood supply's capability to furnish the nourishment needed to make bone. The scale gets tipped and you get AVN. Okay. Once kids are over the age of about 7, those ligamentum teres vessels are fully developed and they're working. That's why you see this leg calf Perthes disease decrease after that age. Okay. So we don't really know, again, why it happens, but we just know it follows a course of blood supply gets interrupted, the bone tries to revascularize, but it's laying crappy bone on top of dead bone, and so it structurally is not good, okay? And this picture kind of shows, the blood flow getting stopped for some reason. And you try to revascularize, you try to start feeding the epiphysis again, but you're not feeding it very well. There's a kink in the hose, you're not watering your lawn, and then it can't make bone at a good enough rate to sustain the structure of the femoral head, and so you'll just see it collapse. So it's not really, that's why it's not an abrupt onset. They'll just, over time, it'll just kind of hurt a little more, hurt a little more, hurt a little more, because that femoral head's just kind of falling in on itself, okay? It's not dislocating, it's just the dome of the femoral head is collapsing. Now, you are technically getting subchondral fractures. You're getting little mini bony, many fractures underneath the cartilage. And so it's just not, the architecture of the bone's not good. The scaffolding is not good, and the tent kind of falls down. So again, little boys, all of a sudden they have a limp, doesn't really hurt them. Usually it's worse after they've been up and around for a while. They'll wake up and be just fine, and then at the end of the day, their leg will be hurting. Pain is not as common with this one. These kids, okay, so dysplasia, when the femur is behind the acetabulum, they can't roll their hip out, right? Because it's stuck, because it's not sitting in the socket. But with these kids, they'll lack internal rotation. And as you know from doing your physical exam, internal rotation is kind of hard to assess. In a kid, it's easy. Lay them on their belly and just see if their legs are falling apart equally, okay? And again, you can kind of do that roll test just to kind of see if there's any tenderness, you know, when you're rolling that hip around in the joint. And then you'll see that on the x-ray, you're going to nail this on x-ray. But what you have to know is you cannot just order an AP of the hip or an AP pelvis. You have to get a frog leg lateral. Okay? One view is no view. Have y'all heard that yet? One view is no view. Do not hand me one view, ever. Do not ever order one view for your preceptor in orthopedics. Okay? Order two, at least, sometimes four, if it's the need. So, if you're ever looking there going, what x-ray should I order? Just order one that has 2 or 3 views. Probably be okay. All right? Do not give them one view. Because if you saw an AP, it might look normal. And that comes into play even more here when we get to skippies. But you'll see this ginormous increase in the joint itself. Okay? The growth plate is smaller and the joint is larger, okay? And this one is very obvious. And if you're like, oh, that might be, I'm not really sure, MRI these kids, okay? If you're not 100% certain on your x-ray, this is a good time to get an MRI. So small epiphysis, wide joint, always compare it to the other hip, okay? And kids are easy to get bilateral hips on because their pelvises are small. So you get an AP pelvis, bilateral frog leg bilateral frog leg laterals. Okay, so you can compare one to the other. And because this is a young kid, they can get the frog leg laterals on the same x-ray. Okay, early in AVN, this is what you see. And this is for kids or adults. This is an adult. I just wanted you guys to see what the crescent sign is. Okay? You got to be really good to notice this. But you'll just see the cartilage. You'll just see the dome is nice and smooth, but then you're getting this drop underneath. Can you guys see that? Mm-hmm. You can see it even better on the CT. This is a CT, basically just a super x-ray. You'll see that it gets just that little, so when you see a CT of a hip that comes back and says early AVN, they're probably seeing something like this. Here's your treatment. He gets to go in Forrest Gump. So these kids need a referral, they need to be followed by somebody closely. So again, I even worked in general orthopedics and we referred these kids. I mean, sometimes we would watch them, they were really mild, but most of the time they're going to get referred on to Peds. So again, just like the treatment for hip dysplasia, the treatment for this is to contain the hip, the femoral head, and the acetabulum. And actually kids, if you can let it have time to revascularize, these kids can catch up, some of them. If there's too much of the femoral head involved and it's just a big crumpled up mess, then maybe not. But if you catch it early, you can actually let these kids grow, let their bone do what it's supposed to do, and they'll kind of remodel. Now they may get a hip replacement when they're 50 years old, but you may not have to do anything until then. So the other good thing about this, the younger the kid is when you catch it, the earlier you catch it, right, and the better they're going to do. So it's, again, being smart about assessing your limbs, okay? Bring them back in a couple weeks and check again. Like if you think, oh, it may just be a transient synovitis, but I'm going to keep leg calf herpes on my, because it's a boy, and they're 5 or 6 years old, so I'm going to keep that on my list, but it's probably transient synovitis, so let's reassess him in 2 to 3 weeks and see if the limp's gone away, right? That'd be perfectly fine to do that. But follow up, if they're still limping, if you haven't already got an x-ray, get an x-ray with what to use. Don't forget the frog leg. And refer if you have any questions, you know. Never hurts to let an orthopedist look at it. Okay, skiffies. You guys already talked about this anatomy a little bit? Okay. This is your typical patient. Adolescent, obese, African American male. Okay? Or female. But it's almost always male. 2 to 3 times more common in males. And it happens later in males. Girls will actually present with this a little bit younger because their growth plates close earlier. Okay? So, whereas you might think a skiffy could occur in a boy around 13, 14, 15 years old, well, it might occur in a girl at, 11, 12, maybe even 10 if they're early, they've grown early. Obesity is your #1 risk factor for this, other than being male. Overweight, male, limping into your clinic with the foot turned out, Dellenberg on that side, that's probably a skiffy. So this is an instability not in the joint, like with hip dysplasia. This is an instability of the growth plate itself, okay? So when you think about that, that makes total sense, right? That obesity would make the growth plate unstable. Okay, the growth plate's already mostly cartilage. It's growing bones, turning over, making new bones. So that's why obesity is a risk factor for this, because it puts too much force on that growth plate. Awesome. So this is painful. So leg calf perthes, painless limp, skiffy, painful limp. Okay? This is one that'll present with knee pain. 2. So if you get an adolescent male that's overweight complaining of knee pain, do not forget to x-ray the hip. And if you x-ray the hip, do not forget to order what view? Frog leg lateral and naked. Right. So this is less of a Trendelenburg gait. This is going to be more of an antalgic gait, and they'll have their foot kind of turned out. This is a good physical exam thing to know. They have obligate external rotation with flexion. And I put a video on D2L for y'all. So you lay them on the bed. Most of the time, you lay them on the bed, they have a left-sided skiffy, they're going to be laying like this. Already. You won't have to do anything. You'll be like, oh, yeah. Now, if you're not sure about that, if they're just turned out a little bit, you pull them up into flexion, and they just have obligate external rotation. They can't even hold it in as you flex their knee up. Okay. Yes.
So what would be the difference between that and a dislocated hip?
So dislocated hip. Are you talking about with dysplasia? You're talking about the hip fracture.
Like a fracture.
The age of the patient. How they came into your office. They came in walking with a limp. They probably don't have the posterior hip dislocation. So now, congenital hip dysplasia is a chronically dislocated hip, right? They'll be short-legged on that side, whereas this is kicking it out and rolling it out. So with skiffies, with dysplasia, it's pulled back and it's behind them. So their gait will be more like a Trendelenburg gait, and their hips displaced posteriorly, so they might kind of kick their butt out, and then they might waddle on that side, and they, what's another obvious clue? When you pull their legs up, they won't obligate, they won't want to externally rotate. So when you pull them up into hip flexion, if it's dislocated, it's not going to fall out. Where skiffy is just going to want to go that way. Does that make sense? And then you pull them up to look at limb lengths, and your dislocated hip is grossly out. Okay. Now with femoral neck fractures in older patients that fell and broke their hip, they're going to be laying externally rotated in bed for sure. So that's a good question. Anybody else have any questions about physical exam on that? Because there's little keys you can use that are like, oh, that's what she meant, that's what makes total sense, you know? So use that flexion, that hip flexion to see what their hip wants to do. If it's dysplasia and it's posteriorly dislocated, it is not going to want to go out. But in skiffy, it's just almost not going to do anything but roll out, okay? Roll externally. So the thing is the ice cream cone falling off, or ice cream falling off the cone, okay? These displace medially. Hip dysplasia displaces which way? Posteriorly, and the whole thing dislocates, right? This, the epiphysis slips off medially, okay? And you will not see it sometimes on an AP. You will only see it on that frog leg, okay? You also want to be comfortable with using Cline's lines because if you draw that, going back to my hip here, so if that's your hip, and here's your socket, if you have a slipped epiphysis sitting down here, if you were to draw a line, that line's not going to hurt. That's a pretty sad looking femoral head. But if that line won't even touch it, okay? Whereas if it's a normal hip, that part of that line is going to go, it's going to go through at least part of the femoral head, right? So you can use those Cline's lines really, you can, and the way x-rays are now, they're all digital. You can just draw the line right there on the x-ray with your little mouse and look at it. So here is where the line might be helpful for you. I mean, obviously, I think y'all are going to be able to figure that out. But you can see if you drew Cline's line straight up, that not even a part of that line is going to touch that. If you draw it up this, it's going to be just enough to touch the femoral head. Okay? If you can't diagnose that, we need to come back. Another picture of the same thing. This one too, I'd like to see the AP of that patient because I bet the AP is normal. I bet the AP view, everybody know what I mean when I say AP view, right? I would bet money that AP looks absolutely normal. These growth plates are almost closed. But you get the frog leg lateral and you visualize that line, you're going to make the correct diagnosis. How do you fix it? Well, you send it to an orthopedic surgeon. Oh, these are fun and easy. It depends on how bad the fracture is, or how bad the slip is. But most of the time, if you catch it early enough, this is why you do need to catch this early, because you can just throw a screw in there and stabilize it, and it should be okay. If you catch it really early, you can just make them non-weight bearing and give them some time, let them have the time for their bone to heal. So basically, you're just trying to heal it in the position it's in, right? So it's in a horrible position. Sorry, we're going to put it where it is and hope it doesn't move anymore. That's the kind of the bummer with this. If you don't catch this early, you can't put the epiphysis back where it's supposed to go. You can just put it where it is right then and keep it there and hope for the best outcome. So that's why you guys need to be good at detecting these. If you have your adolescent limping, obese person coming into the office, it's a skiffy until you've ruled it out. Okay, and you get which two x-rays? Both hips and compare. Okay. Oh, I love these. Yes?
Will it remodel?
Yes. So, depending on how bad. Yeah. The bummer on this is if you miss it and it's horribly positioned, you go ahead and put a screw in to kind of keep it where it, try to stabilize it best you can, you're going to probably replace that hip. That's why you see sometimes now 30-year-olds with replaced hips. may have been this. I have a friend that I worked with at OSOI who had her hip replaced. She was probably 28. I guarantee you it was a Miss Skiffy that healed in a bad position and she got a total hip, which she loved it. But she was an overweight Native American female, so she might have had some dysplasia too. She would have been at risk for all kinds of hip problems. So, all right, moving on. Okay, these are going to go through just really quick. So, any questions on the limping kid, hips, anything just totally not make sense, all kind of coming together for you? Okay. Osgood slaughter, who had it? Anyone? My sister had Osgood slaughter. So this is basically, I mean, you can call it a tendonitis, but it's more of an apophysitis. It's an inflammation of the growth plate of the tibial tubercle. So don't get fooled, and I'll come back to this slide in a minute. When you see this, that's not a fracture. That's the apophysis of the tibial tubercle. Okay, there's a growth plate there at the tibial tubercle. So this is almost always active kids, jumpers, volleyball, basketball, tall, skinny, active kids, runners. My sister got it because as she grew, she kind of got knock-kneed for a while. She was an ACL waiting to happen too. But she never tore her ACL. She had Osgood slaughter, but she had patella instability. But by the time she grew and all her muscles got strengthened, she didn't have it anymore. So this is just chronic stress on the growth plate where the patellar tendon inserts. Okay? So you'll see this in adult runners, and it's called runner's knee or patellar tendonitis. So it's the same thing. It's just in kids, it's a growth plate injury. It's overuse of the growth plate. It's putting too much stretch and strain on it. These kids are probably still really active. They probably have not stopped their sport. They just hurt. So you ice them, you counsel them, you x-ray it and make sure there's not a big fat osteosarcoma sitting there, and reassure them. Now you don't necessarily have to do an x-ray on everybody. I mean, if you are certain clinically that it's patellar tendonitis, then call it, treat it, bring them back in and check on them. The thing is with these, though, is they are not going to get better if you keep doing your activity. You've got to let the parent and the kid know that. You can keep playing basketball, you can keep running cross country, but if you keep doing it, it's not going to, I can't get it to feel. You can't get it to feel better unless you stop your sport, which they do not like most of the time. So usually avoidance of sports for 2 to 3 months to get it to go away completely. Nobody likes that. Yes?
Have you ever seen the bands that they put on the knees? Do you think those work?
I'm kind of mixed on those. I think they reduce the, so she's talking about a band, and I thought I had a picture at one point, but it's a band that kind of goes on the apophysis to kind of divert some of the tension on the patellar tendon off the patellar tendon. It works better for runner's knees. The problem with using them for Osgood slaughter is you're actually putting the band on the spot that hurts. You know, you're kind of putting it on the tibial tubercle. So they work better for runner's knee, I think. It's something you could offer. They make patellar tendon bands, and you can go to any sporting goods store and find a band for runner's knee or something. You can let your patients try that, and some of them may say it helps. Whether it does, I don't know. But people like to think they're doing something to help it. You know, I do think it works better for runners than for apophysitis. Okay. So once they do return to activity, you've got to modify their activity. You know, you've got to say, well, maybe you shouldn't play volleyball, maybe you should swim. Or take, you know, just modify the activity. It depends on how badly they want to play the sport, how much they love the sport. If somebody really loves the sport, they're going to play through pain. As long as you're not missing something bad, let them. That's my belief. I've never, ever seen anybody have surgery for this, so I wouldn't even really list that as treatment. Nursemaid's elbow. Everybody feel confident that they can diagnose this and treat it? Okay. So usually it's some kind of swinging, or I picked my kid up by the arm, or it's not usually child abuse. It's usually just that radial head is easy to sublux anyways. It's usually an accident. So the kid will be like, mom will be like, man, she cried like gangbusters, and then now she's fine. And she's sitting there, but she won't pick her arm up, and she's kind of protecting it like that. And then palpate the radial head. Oh yeah, that's the spot. That hurts. They're guarding it, and then you just try to distract and reduce. So put the thumb over the radial head. Flex. Sometimes just supinating it, you can feel it pop back in. Just supinating it in. But if you don't, if you feel it pop back in, go ahead and flex it up, and that'll usually plunk it right back in. Easy to treat, and you'll be like a rock star. And then I think it was Scott Interwitz that said, then give them the lollipop and see if they reach for it with that hand. And you know your treatment's successful. All right, I'm not going to spend a lot of time on scoliosis. Reduction for females, for adolescents. You're going to see this kind of at the growth spurt of puberty. You all know how to check on physical exam for it. There's no one reason why somebody gets scoliosis. It's multifactorial. Prevalence, about 2% of the population. So what you're looking for too, besides that, the Adams test, you know, bending them over there, you know, bending them over and looking, just looking for asymmetry of the shoulders, asymmetry of the pelvis. You all know this. They actually have scoliometers that you can put on your phone. So if you're tracking someone, it would be helpful. You do need to have some mild grasp of using Cobb's angle. Okay? I'm not going to have you calculate this on an exam, but I want you to understand what it is and how the orthopedic surgeon is following it. So they just take the biggest tilts at the top and the bottom. They're looking for that apex. They have, I'm sure, lines they can draw right there on the x-ray digitally to then calculate that angle where they intersect at 90 degrees. So again, don't waste a lot of time knowing how to do that. I just want you to understand when somebody says Cobb angle, what was the Cobb angle? And you're like, something to do with scoliosis there, whatever. You don't need to MRI these people unless there's something neurologically going on. If they've got some deficiency in their leg, foot drop, if they're circumduction gait. I mean, if there's something that looks neurologic going on, then you need to check their spinal roots. But if their neurological exam's okay, it's unnecessary. Here's your treatment. So you're just going to try to straighten them up as they grow. That's why you want to kind of catch it early and then try to mold them as they grow to try to straighten it out a bit. Okay. So you can get all kinds of fun designs on your braces. That's purely because it's girls that get this. That poor kid in the leg cap Perthes brace did not have any. Have not bejeweled his Forrest Gump braces. These girls have. Okay. Everybody remembers osteogenesis imperfecta, right? Connect that in your mind with blue sclera. Early deafness, why? Yeah, you got bones in your ear that help you hear, right? Okay. All right, the bad stuff. I think the doctor talked briefly about this yesterday. Osteosarcoma and Ewing sarcoma, you guys are the two I want you guys to be able to notice on x-ray, okay? Osteosarcoma is going to be the more common of the two. It's actually the third most common of all the childhood cancers, so you need to be able to know how to recognize it. It will always present an area of rapid bone growth. So why do your growth plate, what's the point of your growth plates? To grow. But they're making bone, kind of just slowly letting that height extend over time and length, increase in length. So they're going to happen at the long, usually the long bone diaphysis. Okay. So, metaphysis, where it's at the growth plate, okay? So it's going to be most common at the distal femur and the proximal tibia. So these are almost always going to be knee pains. You can see them in the proximal humerus as well, but almost always it's going to be around the femur or the tibia. It looks like this grossly. Pretty impressive. It just busts out of its periosteum. So that's where you'll need to be able to recognize with these malignancies, there's going to be periosteal change on the x-ray. They're just going to be coming out of the cage. The tricky part on these is they present with limp, my knee kind of hurts after I walk around, but the thing is it persists, is it persisting over several weeks. A lot of times the overlying skin on these will get warm, not on the joint really, but maybe on the distal femur it might be warm and swollen, or the proximal tibia it might be warm to the touch, look puffy. It will have classically a sunburst appearance, okay? And you'll see where it's kind of coming out. What I want y'all to realize, it doesn't lay on top of the periosteum. It affects the periosteum. You see how that lift, you can see that lift of the periosteum there? What lab tests will be abnormal on this? They're out of box because of all that bone turnover, cancerous bone turnover. This is a pretty impressive one at the proximal humerus. I mean, if you can't diagnose that, you gotta go back to school. But again, you'll see that lifting of the periosteum. Okay. Ewing's is usually extremities. It's usually the entire shaft. It's not just bursting at one spot. It's usually going to lengthen along the bone. It's usually pretty extensive. This one's bad. Okay. The problem with osteosarcoma, you catch it early, you can sometimes do a limb-sparing surgery and survive that. This one's kind of worse prognosis for Ewing's. The classic radiographic change on this is the onion skin. Okay. So again, you'll just see. It looks like layers of an onion lifting up. Again, changes in the periosteum is what you'll see on these. This is a little bit better picture. So look for, if you're not sure what the heck's going on, look at the periosteum and see if there's changes there. That's the first place to look. More pictures. Sunburst versus onion skin. All right. Which one's malignant? Who thinks they know? Left or right? Yeah. The right is malignant. This one actually is an inchondroma. It's not busting out of the cage. even if it was right up against the periosteum, it would just stay in it. Okay? Whereas this one, you're seeing major periosteal change, right? Seeing this periosteum lift here, seeing this lift here, all that in the skin there.
What'd you call the one on the left?
Inchondroma. Inchondromas are kind of, they look kind of cloudy, like it almost has like you can see that this has got cartilage in it because you got all these gaps, this cartilage is radiolucent, right? It looks like there's cartilage mixed around in it. Could be a little more like an inchondroma, but again, it's maintaining itself inside the periosteum. Okay, which one of these is malignant? Anybody want to take a guess, left or right? Correct.
What's it gonna say?
This one is malignant. This one is actually like a bone fibroma. It's like growing on a stalk. It looks like broccoli. Like it looks like it's a stalk of broccoli growing on the outside of the bone. Like it's just this perfect little, and then broccoli head. Those are benign. But again, here, this one's a little trickier because you don't see a ton of periosteal change. But it looks like an inchondroma, but it's outside the periosteum, so it's malignant. Okay. Anybody want to guess which one's malignant? Left is malignant. Why? It's effect. Yep. You're seeing lifting up of the periosteum. You're seeing, like here, it's really funky. You've got this whole malignant mass growing outside the bones. This one, I think this one's just kind of a benign chondrofibroma. I mean, it's just not, it's just full of fibrous tissue. There's really not even any bone in it. But those can also be a problem if they get that big, because you can get a pathological fracture around it. But I'd probably send them for a consult on that one. Okay, fractures of the growth plate. Why are we worried about fractures of the growth plate? It will stunt the growth, right? If we completely destroy the growth plate. Look at what happened to this poor girl. I think that's a girl. Somebody didn't follow up on that one. Which growth plate's closed? She has no growth plate there. This one's still a bit open. So she had some type of a fracture that closed her growth plate early, and this femur kept growing. This one did not. I would think she has a leg length discrepancy. What do you think?
So do they shorten the one leg or lengthen the short leg?
So on this one, that's a good question for a pediatric orthopedist. They would probably try to lengthen that one, but they may have to meet it in the middle. You know, that's a big problem there. A lot of these can be fixed with just taking out a wedge of one side if you catch them early enough. But anyways, don't miss them. The other thing is if you don't, so this girl got the entire growth plate was shut down, right? What happened to this person? That person had a portion of his growth plate shut down, and so one side quit growing while the other kept growing. So one side of this tibia stopped. This side of the tibia stopped growing. This side kept growing, so you got an angular deformity of the ankle. Okay. So you can. There's two reasons to not miss these. You're either gonna you have premature growth plate arrest, and the whole long bone stops growing, or you shut down a portion of it, and then you'll get angular distortion. Those usually happen at the ankle, and more common at the ankle. Okay, Salter-Harris. Does anybody feel like they've completely got this worked out in their brain? Okay, everybody should know what a 1 is, right? A 1 is just a fracture through the growth plate. It will look absolutely normal or can look absolutely normal on x-ray, especially if you only get one view. One view is no view. Because you might see this on the AP view, and then you might see, it's like that there. And you might see that on the lateral, okay? So, a 1 is all the force of the injury went straight through the growth plate. You need 2 views to assess it appropriately, okay? 2s are the most common. 2s go in the growth plate and they go out the metastasis. So you'll see a crunch right there. Okay? So the injury, the force of the injury has to go somewhere. So it starts in the growth plate, but then it doesn't exit out the other side of the growth plate. It exits through the metastasis. Okay? 3s the force enters through the growth plate, but then it comes out through the epiphysis, which is worse. Why? Why would those have a poor prognosis? It's in the joint. So if you don't align that, if you don't align those pieces up properly, this person is going to get arthritis. This is why fractures are a risk factor for arthritis later. Because if it goes in the growth plate, out the epiphysis, cartilage has been injured right there for the fracture to go out through the joint. Okay? Worst prognosis on 3s. 1, 2, 3. 4s. Fours don't even start in the joint. They come through the growth plate and affect both sides. So they don't really go, the force doesn't enter through the growth plate, it enters somewhere else and it takes out the whole end of the bone, okay? It's going to affect the metastasis, the physis, the epiphysis, and the joint. So this is even worse prognosis, okay? I'm helping you guys think like surgeons, because if you look at it on an x-ray as a first-year PA student, you're going, I don't know what the hell that means, right? You need to be able to find 3s and 4s, okay? Because 3s and 4s are the ones that they've got to operate on to stabilize, or that kid's going to get screwed at something, okay? 5s are really rare, very uncommon. That poor girl with the short femur probably had a 5 and just crushed her growth plate. So 5s are just, the growth plate just gets smushed. And I mean, wrists can do that, falling on an outstretched hand and just completely injuring the entire growth plate across, okay? Does that help? You've got to think about where the force went through. That's how you need to think about ankle fractures too. You can think about, where the injury, the force applied, entered and exited. That helps you see what happened and what's at high risk. Yes.
Would 2 shut down half the growth plate?
2s usually don't. They can, depending on how severe it is. Again, but 2s actually are the most common, and they've got the best prognosis. 1s and 2s usually will be fine. Now, but if that piece got completely displaced down, yes. So that's why you'll see sometimes, being from orthopedic surgery, you'll see sometimes they'll put a screw in that lateral mouth. That lateral mouth's falling off. So they'll just screw it back up in there to maintain the joint and maintain the growth plate. Okay. And again, the injury it's done. You can't rewind the clock. They're already injured. You just have to make sure you're aligning the pieces the best you can to not cause the patient later problems, So you would never tell these patients, oh, we're going to completely fix everything. It's going to be just like brand new. This is not a good thing to tell a patient. Like, you had a horrible injury, we're gonna try to put things back in the best position that we can to give you the best outcome you can get. If we don't do anything, you're gonna get arthritis in the ankle, or you're gonna get an angular deformity from shutting down a portion of the growth. More dorky cartoons. 2s are the most common. 3s have great. Now 3s, if a kid, if it walks like a duck, talks like a duck, it's a duck. If you think they fractured it and you think it went through the growth plate and you don't see anything on x-ray, it's probably a type 1. Put a cast on it. Or don't cast it if it's horribly swollen. That's a whole nother lecture. But immobilize it, send them to an orthopedist. Let the orthopedist decide if it's a type 1 or not. Okay? You treat it like it's a type 1. It's like you're thinking, my gosh, I think this kid's got a fracture. Well, he probably does. He probably has a Salter 1. Okay? I don't like this. I wish I would have taken it out. I don't find it helpful, but if you want to use it, you can. Okay. Now you guys get to tell me what type they are. I should have brought like bubble gum or something, thrown it at you.
Type 2.
I'm fine. That's a 2. Yep. So the force of this injury probably came through here or through here, but it just took off part of the metaphysis. And this person got another view, like they should. You see that it's not horribly displaced. Okay, so that's a 2. What I need to do is just pull these next. Okay. 1. Yep. If you only ordered an AP, would you list that?
Yeah.
Yep. I always like to get 3 views of the ankle, an AP, lateral, and an oblique. So you're seeing it in 3 dimensions, even, 3 dimensions. It's like, so this you'll see here, it's just slipped back. So you'll see this step off. It should be, see, step off here, step off there. That one might do okay without doing anything. Again, that's what orthopedist's call. You might just cast out and see how they do. What's this one? Who sees the fracture? I'll give you a hint, it's not the growth plate. What do we call this?
green stick.
Nope.
Oh, it's okay.
That's a buckle fracture. It's where the cortex of the bone buckled. And it's probably a fall on an outstretched hand, right? And there's no involvement of the growth plate at all, right? You guys, when you have some spare time or when you're on rotation, we're going to be seeing a lot of peds, flip through pediatric x-rays and look so that you know this is not a fracture. Know where the growth plates are. Buccal fractures heal up so easily in kids. You can usually like cast them for 3 weeks and take it off and they're totally healed. So, buccal fracture or torus, they'll call it a torus fracture. It's the other word. Okay? This is intellectual achievement. I saw this stuff. It might be a 4, yes. So you could probably have an argument whether this is a 3 or a 4. I think it's a 4 because of this little piece right here. So it's definitely a 3. But then I think when it exited, it got a piece of the metaphysis as well. So probably, and look how wide that joint is. That is going to be a problem. And so they would probably put a screw in this. So this patient, so this is tricky. This would have fooled me on my first 6 months of orthopedics. You can clearly see the growth plates are open. So compare the ulna to the radius. The growth plates are open. It looks really open and more open on this side. I mean, I think this is a crush to that portion of the radius. What do you think? So this is probably a 5, but it's just affecting from about, oh, sorry. It's just affecting from about here over. Y'all see that? That, I mean, this would have to be watched because they might get some arrest of that side of their growth plate. And you can do things to fix that. Orthopedic surgeons can do things to fix it. They can do osteotomies and things. They can take out a wedge on the other side so they grow at the same rate and things like that. So just you need to make sure you're catching it and sending them to a specialist. Okay. Big toe. I definitely think that's a 4. What do y'all think? Because you see it, the force went into the force may have come in through the joint, or the force may have come from out here, but it's gotten a part of the metaphysis, went through the growth plate, exited into the joint. That person's going to be at risk for arthritis in that later in life. So probably a 4. I see a 4. This person's about done growing. Can you guys tell that? It's probably a teenager. But you see fracture through here, through the growth plate, and then out through the joint. And that's pretty stable. And you see the difference between this one, how there's not a big widening of the joint right here, versus this one. Look how wide that joint is right here. That's not good. But in this one, the joint line actually looks pretty good. So you might just be able to non-weight bear that person and cast them and just watch and see if it heals in a good position. You would x-ray them the very next week, and then maybe the very next week after that, make sure that that piece isn't slipping. Okay? And you guys don't need to know all that. You'll know that when you go do orthopedics. All right. 4. So that's where I don't want you to miss these 4s in fingers and toes, because they can be kind of tricky. But see, you got a piece of the metaphysis there with this fracture. You can see that little piece of the metaphysis is broken off. So it's technically a 4. You might pin that. Three. But that is in the joint, so you're going to want to watch that very closely. So that's a 3. Okay. Quick case studies. And I'll let y'all go. Okay. 21-month-old male refuses to bear weight on the right leg for 2 days. Previously has walked for 12 months. Could run, but suddenly now refuses to even stand on the right leg. No history of trauma, no fever. Walked at 12 months, speaks 3 to 4 words, no developmental problems. Right knee, no swelling or warmth, no tenderness palpation, the knee. Right hip, abducted and externally rotated, normal range of motion, no skin erythema, no ecchymosis, no warmth, swelling, right ankle's fine. What do you think this person has? What would you like to order? If you haven't figured it out on your history. You didn't need an x-ray. This person probably has transient synovitis. Okay. More common in, older than or younger ages. no fever. Now I have, let's see, I have another, and you don't see anything on your physical exam, like the knee's fine, the hip's fine, the leg's fine, there's no problems, just go with it, it's transient synovitis. He's pissed. Limped off and on for the last 1 to 2 months. 1 week, he's now for 1 week had a little bit of pain in the right upper thigh and groin. He's 6 and he's a male. No history of fever, recent upper respiratory infection. Never had any problems prior to this. And definitely going to want an AP and a proclavicular, right? The joint, there's nothing on your exam other than guarding of the right hip. What else did we check him for since he hurts in his groin? Checked him for a hernia. Okay. And you examined his knee because he has hip pain. Examined his hip, he has knee pain, right? This is more like real life. And you get this X-ray back and you're like, I think he's got some AVN. Your first year in clinicals, you probably won't be able to know that, but you can see a little bit of AVN here. It's early. But go off your history. He's a 6-year-old boy. The insidious onset of the limp. He never had any problems prior to that. He's not sick. He's not obese. So he's got limb count groups, right? And then there's your X-ray. It's more obvious. So you might see this early, and then you might, and that's what you're going to see later. You miss it. You don't want to miss that. Okay? So if you aren't sure, X-ray it in 2 or 3 weeks. X-ray it again. Bring him back, see him again, X-ray it again. And if he came back, I'd be like, okay, now you're going to go see the orthopedist. We're going to need to probably put you in braces or something, right? You haven't done anything wrong by just following him, seeing him back. Okay. This is a 13-month-old girl. Who can already tell me what it is? She began walking about a month ago. Mom's concerned because she's limping. She's otherwise developed normally. She's had no other symptoms at all. She hasn't been waking up at night. She hasn't seemed fussy. She's just limping. She's not complaining. She's walking, but she's just limping when she walks. She lacks external rotation. She's shortening of the left femur. So you guys already have your diagnosis, right? What do you want to do for her? What test do you want to perform? Yeah. You want to do your maneuvers and see if you can feel that she's out of the socket. For her, she's already 13 months old. You could X-ray her. But if you want to send her for an ultrasound, you could. Either one, really. You just cannot. There's no point in X-raying if they're less than 6 months old. And if she'd been seeing a good primary care provider, she'd already been diagnosed with hip dysplasia when she was a newborn, right? Okay. Any questions about that one? No? Okay. What's he got? You don't even have to read it. So he might present with anterior hip pain 2 months ago during basketball season. He's told he had a groin strain. And he's treated conservatively and continues to play. He now has worsening pain in the same area and has started to limp most of the time. He has nice fever and no other complaints. Worried that he will not be able to participate in summer conditioning because of the pain. His other, there's another spelling. Developed, no, with an E. So, family history's fine. He's active. He's BMI. He's a little heavy. What's on his exam that you noticed there? He lacks internal rotation. He walks with his toe turned outward. What's he got? Now, this is a good sign if you don't really see it on the AP. I mean, if you're drawing your line, you're being really good, you might be able to draw Cline's line on there and see that it's off a little bit. But then you get the frog leg lateral. And it's clearly not a skipping, right? But this is a good example of needing the frog leg lateral until you get really confident in diagnosing it. And then you can still order it. Okay, left knee pain. Healthy 13-year-old female kicked during a soccer game. She developed pain in the anterior knees, persisted for 2 months. It's affecting her ability to play. No other complaints. Symptoms are worse after soccer practice. Ice and NSAIDs help. It now wakes her at night from time to time, and there's localized swelling. She has slightly limited range of motion, tenderness of the proximal tibia with localized swelling and warmth. She has no point tenderness of the tibial tuberosity. It's a bad deal. So that's just a sign of, yeah, oh, it's sounding kind of like Obligate water, you know, she's a soccer player. But then when you do your exam, you're like, oh, she's not really tender on her apophysis. She's not really tender at the insertion of the patellar tendon, is she? She's more in the proximal tibia down, you know, where it's warm. And don't miss that with the x-ray. And she probably does have a lot of good slaughter. Look at her growth plate. But the problem is she's got a big, fat, ugly cancer sitting in her proximal tibia. That's what it looks like on MRI. All right. That's just, you all can look at that on your own time. Question?